Hi, good evening, sir. This is Gunjan. Good evening, Dr. Mahala. Good evening, Dr. Kanchi.
Good evening. Are you able to hear me?
Yes, sir. Loud and clear.
Good evening, sir.
Good evening.
Good evening, Mulli, sir.
Good evening.
Good evening, sir.
Good evening. All good. Huh? All set up.
Yes, sir.
Yes, sir.
Great.
I think Dr. Anup sir will join now. You want to see just once, no?
Sure. Anup Mahala and Varun Shetty.
Dr. Mahala is already there, sir.
Yeah, Dr. Mahala is there. That's great.
Yeah.
Vedant and Srinivas will join later, I think.
So today we have first session, sir, by Dr. Varun Shetty.
Correct.
Yes. Then followed by Q&A and then case by Dr. Anup and followed by Dr. Mahala, right?
Correct.
Yeah.
Gunjan, Anup sir is having some problem that meeting host will let you in something is getting.
So,
Can you just check?
Ruchit, can you let in Dr. Anup, please? He must be waiting in
So
lobby.
I have let him.
Okay.
Okay, you are there now. Hello, Anup sir.
Yeah, Dr. Anup is
Can
in.
you?
Yeah, yes.
You can just share your slide, sir, if you want.
Yes.
Dr. Muralidhar, I wanted to ask that Dr. Kedar is joining with the slides.
Host has disabled screen sharing. Can we just allow me to share?
What is that?
No, so sorry, sir, not you. I was just talking to the host.
Okay.
Ruchit, can you please allow Dr.
Can you
Anup?
make us? Can you make me as co-host as well? And me and
Hello?
Gunjan both.
So, Ruchit, can you please allow Dr. Anup, Dr. Muralidhar Kanchi, Dr. Mahala as a host so that they can share the screen?
Okay.
Yeah.
And
Yeah, we
you
are
can
given
make
the
us
right
a
to share the screen. You can share it away.
Okay.
Gunjan,
Yes, sir.
there is on my behalf, Dr. Kedar is going to talk. Okay.
Yes, sir. Yes, sir.
He has to ask him. He probably doesn't know how to share slides and join in the meeting. But
We did a dry run with him, sir.
yesterday,
He
sir.
shared the slides.
Fine. He
Yeah.
should join and talk because he sent me the slides. It is without the video supporting files. It just came blank images to me.
I will
There's
talk
nothing.
to him, sir, right now. We'll get it done.
Yeah. Okay.
Can you see my slides now?
Yes, sir.
Yes,
It is
yes.
up.
All right, okay. I'll just try moving it.
Yes, sir. It has moved.
Okay.
Yes, sir.
All right. Okay. So I am logging in through the Mac.
Okay.
Okay. So I hope any other troubleshooting we have to check right now, or should I log in through the Android? Or
No, sir. It
Windows?
is working fine. I think it's not an issue. You don't have any videos, right, sir?
No videos.
Yeah, then it is fine, sir. It is working absolutely fine. I don't think you need to log in from some other device.
All right. Okay. Anyway, but I'll do one thing. I'll just log in and keep my other device as a standby just in case.
Yeah, that would be great, sir.
Okay.
Yeah,
Okay.
as a backup.
Yeah, as
And
a backup.
sir,
But yeah,
and sir,
yes,
if you
Rakesh.
want to see the readings and all, na, which we are going to change, so you can have a separate device for that. If at all
you mean the
require.
presentation? You mean?
Yeah, or else
Yeah,
you
that-
can. Yeah,
Yeah,
because
that anyway
otherwise
I'll have.
Manoj.
That anyway
Manoj
I have.
will do that.
I'll open up
You have
the
the printout,
values.
right? Yeah. Okay.
The table I'll have.
Manoj,
With
you're joining now. Join now, no? Manoj. Yeah.
So Ruchit, just wanted to check. You have given the sharing rights to Dr. Murlidhar Kanchi, Dr. Anoop, Dr.
Yes, I have given the sharing rights to each and everyone.
Okay. Thank you. Just wanted to be sure.
You can make me and Gunjan co-host.
Yeah.
That
Okay.
will be better. Yeah.
Okay.
How about Dr. Kedar? Has he joined?
Yeah, Rakesh is checking, sir. No,
yeah,
he has
yeah.
not
He
joined.
will join now. He will join now.
Okay.
I spoke with him, sir.
So Ruchit, Dr. Kedar is also joining. His name is not there in the agenda.
He is going
Please-
to present. So the
Yeah,
presentation.
please give him also the sharing rights.
Yes,
Dr.
he
Kedar,
will
he has
get the
not
rights
joined.
to-
He'll join.
He
He'll
will
join.
get the rights to share.
Sure. Thanks.
Dr. Mahala, everything is sorted out, no?
You're on mute, sir. Dr. Mahala,
Sir,
you're
you're
on
on
mute.
mute, sir. Yeah.
He sent me the mail of this presentation, and unfortunately there is no video. I asked him, so he said me that I have sent my PowerPoint, sir. I said, how did you send your PowerPoint to the mail? No, I just sent it. I said, you should have some idea that without sending the supporting files, the videos will never play in a mail. You have not sent me the, no, I don't know. It is new to me, he's telling. So this is the latest development, what I got the mail without the videos.
Yeah. He shows some enthusiasm. That's why I'm interested.
No, fine, but raw is fine. I always prefer smartness, but not using the word over before the smartness. So I'm asking, you have sent me a mail, where is the playing pictures? Nothing is playing. No, you click it, it's going to play.
Just checking my second device.
Sure, sir.
You can hear?
Yes, sir, we can hear.
Right.
Are you sharing something, sir?
No, I'm not sharing anything.
Oh, yeah,
I'll
we
just
can hear
use
you.
this as a backup, just in case if something happens. That's all.
Yeah, we can hear you, sir, loud and clear.
So
No
I'll keep
issues.
this device muted itself, and I'll use the primary one for presentation and all.
Sure, sir.
All right. Okay. Yeah.
Rakesh, there is no disturbance coming, no?
No, sir. It's perfect, sir. No problem.
That's
Perfect.
great.
The library is good, sir. Your background. I think you are sitting.
I'm sitting in the library.
Yes, that's why no
But
noise,
not-
outside noise.
Yeah. But don't ask me how much I am reading. I have to read a lot.
Oh, it appears that you are being in the library means it is not less than the level of a Nobel laureate.
Yeah, just by sitting in the library, we cannot become a Nobel laureate. No.
No, it appears.
Thank you. I'll buy you some sweets tomorrow.
Oh, thank you.
At least you said appears. That's
Good
a
evening, sir.
great compliment.
So we are starting exactly on time
Yes.
and we are keeping time.
Absolutely.
Uh,
I'll just call Dr. Varun Shetty and find out. This 52. Varun Shetty is logging in. He'll be in.
He's joined, sir. He's joined.
Oh, great. So the team is complete. We have a cardiac surgeon, cardiologist, critical care medicine, and then anesthesiologist. All the 4 components are there.
Yes, sir. And technology to support them, sir.
Correct. Correct. Four minutes to go. Dr. Varun Shetty, welcome. Thanks for joining us.
Pleasure to be here, sir.
Thank you.
You let me know what time to start.
We'll be starting introduction at 7.
Mm-hmm.
I think it will be about 7:05 when you actually start.
Okay.
When you actually start. Yes.
Okay, sure. So I'll wait for you to tell me. That's it.
Yes.
Okay, thank you.
We'll be having a crowd of about 30 to 40, I think so.
Yes, sir. So we already have, sir, 20 participants, including everyone.
Okay. We're not expecting a large meeting, large gathering. It's a focused 30 to 40 people. Is the platform open to all the audience now?
Yes, sir.
Okay. We'll start at 7.
Sure, sir. Sure. It's 7, sir. Shall we begin?
Yes, yes. Please start.
Okay, thank you. So, good evening, everyone. Myself, Gunjan Khurana from Edwards Life Sciences. I welcome all of you in this Center of Excellence event organized by Narayana Health in collaboration with Edwards Life Sciences. We have been running this program for quite many years, and it's a very much liked program by all the participants. Due to the restrictions of COVID, we have been doing, this virtually. That's not the best way, but we have been restricted with this. We'll soon try to get back to our physical program, where you can visit the OR and IC of Narayana Health. This session will be for a couple of hours today and tomorrow, and we have the privilege of having eminent faculty from Narayana Health for next couple of hours to interact with all of us. I'll just quickly, share my screen. I hope my white screen is visible. So before we begin into the program, I'll just, have some housekeeping announcements. So please keep yourself on mute when the session is ongoing. And we have a dedicated question and answer sessions, so during which you can unmute yourself and post your questions. We have case discussions also, where you can be on unmute and participate in the discussion. And this session will be recorded for future references, so that will be available. Going into this program, we have 6 eminent faculty from Narayana Health who would be available with us for today and tomorrow, led by our chairperson for this program, Dr. Murlidhar Kanchi, who will introduce all the faculties at the right time. Just quickly running over to the agenda. So today we have a surgeon's perspective on advanced hemodynamic monitoring. This should be shared by Dr. Varun Shetty, followed by 2 interesting cases before closing the event for today. And tomorrow we have a lecture on monitoring cerebral perfusion, again followed by 2 interesting interactive cases before closing the program. So without further ado, I'll introduce the chairperson for the program, Dr. Murlidhar Kanchi. This name actually needs no introduction. Everyone knows him very well, but I'll still try to introduce him. Sir has been associated with Narayana Health for quite some time. Dr. Kanchi is the director of academics, as well as professor of anesthesia and intensive care in Narayana Health City. Sir has numerous publications in various international and national journals, and sir has been invited faculty in various, again, international and national conferences. So without further ado, I'll hand over to Dr. Kanchi for taking the session ahead. So over to you, sir.
Thank you very much, Gunjan, for the introduction and the opportunity to be with you this evening. Colleagues, ladies and gentlemen, I welcome you to this academic program conducted by Narayana Hrudayalaya for Edwards. And we, as already pointed out, we have chosen the faculty carefully who are eminent and who are capable to communicate and who are experts in their fields. We have cardiology representation, cardiac surgery representation, anesthesiology, and critical care medicines represented in this meeting. And to begin with, we have Dr. Varun Shetty, who is a leading cardiac surgeon, a very talented and bright surgeon.
Sir, you are on mute.
Sorry, I'll begin again. Ladies and gentlemen, welcome to this academic event under the banner of Narayana Hrudayalaya, sponsored by Edwards. And we have eminent faculty to lead us through this session. We have representation from cardiology, cardiac surgery, critical care, and anesthesiology. And I would like to introduce Dr. Varun Shetty. To start with, Varun Shetty will be telling us about the surgeon's perspective of hemodynamic monitoring. And Dr. Varun Shetty is one of the leading cardiac surgeons in Narayana Hrudayalaya. He's a skilled surgeon doing a lot of complex cases. I think he's the right person to tell us about his views on the use of advanced cardiovascular monitoring techniques during cardiac surgery. That will be followed by 2 case discussions, and I'll be introducing the respective faculty at that point of time. May I request Dr. Varun Shetty to start his presentation? Dr. Varun Shetty.
Thank you, sir. Thank you. Gunjan, can you just confirm that you can hear me?
Yes, sir, loud and clear. And your presentation is up.
Is up. All right, fine. I'll begin. Thank you, Dr. Murli, for that very kind introduction and for the opportunity for me to speak on this aspect of hemodynamic monitoring. Before I start, I have 2 disclosures. One is, when we talk about advanced hemodynamic monitoring, I'll be only talking about the PA catheter and the continuous cardiac output monitoring, because this is the device that we are most familiar with. In fact, it forms a very integral part of our decision-making and management of critically ill cardiovascular patients. And the second disclosure is, I'm going to keep this talk very simple. Being a surgeon, I am not going to keep it very theory-oriented, very practical, and just a simple take on from a surgeon's point of view. So to begin with, the PA catheter, as I said earlier, forms a very integral part of our decision making, and more importantly, in several aspects of cardiac surgery, whether it comes to evaluating a patient for a heart transplant, or whether he would require a lung or heart and lung, or risk stratification of patients, especially when it comes to patients with CTEPH, because we strongly use the pulmonary vascular resistance as a cutoff, as a criteria for risk stratification. And it is especially useful when we have a lot of experience of putting patients on ECMO and VADs and transplants. So it is important in monitoring these patients, when to put them on the device and how to get them off these devices. But I think the general community or the intensive care community knows that the use of PA catheter is declining, and it only has a role in a very limited role in cardiac surgery. I'm here to explain that it is an often underutilized tool, and it should be more widely used. Right. Here we go. Now, if you were to do a literature search on the PA catheter and its role in current in current use of medicine, it has always got a bad rap. In fact, there was an article written in entitled "The Obituary of the Pulmonary Artery Catheter." And it goes like this. I'll just read a small excerpt from it. The birth of the PA catheter was announced in the New England Journal of Medicine in 1970 by William H. Swan and William Gans. It grew, became very popular. It was used in the management of over 40% of all ICU patients. However, randomized controlled trials in the subsequent future showed that it was of little use. It also became clear that most of the values were poorly understood or misinterpreted. And after that, there were a lot of rivals that came into play: bedside echocardiography, pulse control technology, and they claimed that they could assess cardiac output more easily, less invasively, and almost with the same reliability. To make matters worse, dynamic assessment of fluid responsiveness, pulse pressure, stroke volume variation, and leg raising made a mockery of his wedge pressure. His cousin, the CCO monitor, which is what we continues to eke a living mostly in cardiac surgery in patients who need central access. All of this may be true, and some parts may not so true. Okay. Now, despite the dramatic reduction in the use of PA catheter in cardiac surgery to less than 20% in Europe and less than 10% in Japan, some centers in North America and Australia still routinely use the devices. And these are centers that do transplantation or who operate on patients with pulmonary hypertension. In them, the PA catheter is an integral part of the decision-making process and cannot be overstated. But let's be honest. Let's be honest about the limitations of the CCO catheter. Now, if a patient has tricuspid regurgitation, the value that the cardiac output goes out of the window because it is often underestimated because of the dilutional effects. When calculating cardiac output compared to the direct FIC method, so many papers have shown, both animal studies and human studies have shown that when compared to the direct FIC method, the thermodilution method has a percentage error of 56 to 83%, very wide variability. If the main premise of the CCO catheter, that is the cardiac output, is inaccurate, then all the other derived measurements, several will be inaccurate, such as the systemic vascular resistance or the pulmonary vascular resistance. And also, let's remember that there are many factors that can lead to erroneous wedge measurements. For example, positive pressure ventilation, all of these do play a factor in measuring the wedge. Improper placement, mechanical ventilation, and improper transducing all can affect the wedge. And a wedge has to be done strictly at end expiration and at the early diastole for you, and also it should be positioned in the lower third of the lung for you to get an accurate wedge. And not many people will follow this very strictly when measuring wedge. Now, if you come to what are the directly measured hemodynamic parameters like CVP, pulmonary artery pressure, wedge, cardiac output, and mixed venous pressure, I think the CCO does this very accurately and very reliably. And also, when it comes to the derived values, it does play an integral important role because, as I'll explain later on. Now, speaking from a surgical point of view, the definitive use case scenarios are in pulmonary endarterectomy, transplants, mechanical assist device, or managing patients with severe uni or biventricular dysfunction. When it comes to where a referral center for pulmonary thromboendarterectomy, it is one of our, is one of the most important surgeries we do, and we do it on a very fairly regular, routine way. And all our patients do undergo a right heart catheterization to measure the pulmonary vascular resistance, because we have seen that the pulmonary vascular resistance alone is an important risk factor in this operation. And patients with a PVR of more than 1500 dynes are considered high risk. And that is why these patients should be thoroughly evaluated, and they should be much closer attention should be paid to them. We also use the PA catheter in all pulmonary thromboendarterectomy cases while coming off CPB to assess the completeness of endarterectomy. I don't think any center that does pulmonary thromboendarterectomy can do it without a PA catheter, because the only way to measure the completeness of the surgery is by measuring the pulmonary artery pressure. And also it does play a role in managing these patients with persistent pulmonary hypertension. Now, like in lung transplants, the other complication following pulmonary endarterectomy is reperfusion edema, which is why it's very important to keep the index below 3. And also when selecting patients for CTEPH, one of the main the definitions for patients with CTEPH is that they should have radiological evidence of thrombotic occlusion of the pulmonary arteries along with the measured mean pulmonary artery pressure of more than 30. This cannot be measured indirectly by echo, but has to be measured by a right heart cath to properly label the patient as CTEPH. And the other use of the CCO monitor is we use it to measure the blood temperature. So we can see in pulmonary thromboendarterectomy, we cool the patients to 18 degrees for circulatory arrest. And we measure the blood temperature for both cooling and rewarming. We find that very useful. When it comes to transplants, it's a very important part in the workup of patients and the decision-making to transplants. For example, we use an absolute cutoff of 4 Wood units to say that these patients are not transplantable and should undergo better medical therapy until the PVR comes down to less than 4 before we can accept them for a transplant. It is extremely important to measure the transpulmonary gradient and the diastolic pressure gradient to see if they would require a heart or a heart and lung. Extremely important factor. And also when we are coming off CPB in transplants, it's very important to measure the mean pulmonary artery pressure, the wedge, and the cardiac index, because many of these patients will be vasodilated because of years of heart failure therapy, and the systemic vascular resistance is always very low, and they would require, and it would guide us in the vasopressor treatment of these patients. Also, whether we need to go, a low index, a high pulmonary vascular resistance, or a mean pulmonary artery pressure, or a high CVP, struggling RV, all of this will help in our decision making to go on ECMO. And also it will help us determine whether the patient requires filling, or he requires vasopressors, or just inotropes purely based on the systemic vascular resistance. When it comes to mechanical assist devices, PA catheter and right heart cath play a very important role as well, because during the workup for a VAD, if the patient is not transplantable, then the other option is can we VAD him? And from right heart cath we can assess the PVR or the pulmonary artery pulsatility index. We also use the VAD very routinely when to assess the right ventricle when weaning of CPB. And also seeing the overall function of the heart by the index and the systemic vascular resistance. Post-op management to rule out, RV failure, tamponade, or the weaning of inotropes, the PA catheter is very useful. And also it plays a role in the management of cardiogenic shock, because it would help us better define if this patient is on cardiogenic shock. If a patient has a MAP of less than 60, he's on more than 2 vasopressors, more than 0.1 mics, and you also have an index of less than 1.5, then we are sure that this patient is not going to respond to inotropes, and we must initiate mechanical assist either by ECMO or a VAD. And also, as I said earlier, while weaning off ECMO and VAD, the cardiac index, the mean mean oxygen consumption and lactates play an important role. Now, if you remove transplants, if you remove PTE, if you remove VAD and mechanical assist out of the equation, I strongly believe that these PA catheters still plays a very important role, because we do cardiac surgery on many patients with compromised left ventricular functions, either the right, left, or both. and cardiac index and a CCO and cardiac index, the number is extremely important in managing them, because it will help us measure the systemic vascular resistance, the pulmonary vascular resistance, and it will tell us whether they need any, if it's just PVR alone, do they need any pulmonary vasodilators or INO? And if it's SVR, do they need vasopressors? Do they need inotropes? And also, if these patients are sliding, then there will be some solid clinical evidence to say that the patient will benefit from a VAD or an early ECMO. So in conclusion, I just want to summarize that once again, that I know there are many devices out there, and some of them do give the same values or derive values as a PA catheter, and everybody talks about the invasiveness, but when you're talking about transplant and VADs and all these, what can get more invasive than this? So a tiny little PA catheter is not going to make any major difference if you're just talking about invasiveness, if that's one reason to reject the use of a PA catheter. We find it very useful to track and monitor the progress of patients, and extremely important in the decision making. And also, when you have teams, multidisciplinary teams managing these patients and managing these various clinical scenarios, it will help us with these numbers to help us set up definitive clinical criteria for which one needs to intervene. Now, I put this picture up. This is Ham. I don't know if you know, this is Ham. This is the first chimp in space. He went to space in the 1960s, and he was part of the Gemini missions of NASA. And last year was his, he died 26 years after being launched into space. So he was launched into space. He orbited space for about 45 minutes, and then he was brought back to Earth. Now, to the casual eye, one might think that Ham was trained to fly the spaceship. But actually, Ham was not trained to do anything. He was just expected to be a chimp in space. He was just told, that these are, these are some controls, and this is where, basically the whole space shuttle and the whole orbiting of the space shuttle and the bringing back the space shuttle was done by the NASA team at Control Center, and Ham just had to be a chimp. So I use this example because we often in medicine think that, maybe we can use all these devices and have a chimp sit by the bedside, but I don't think there is any device yet that can replace the human intellect. The human intellect that is very important in cardiacs in the management of these patients as of now. The autopilot, where these devices could understand the data, and using AI and all the other things could understand, maybe guide you into the management. I think these devices will bring up more hardcore data. You'll have analytics to understand it, and directly point and give you suggestions whether this patient requires preload, whether he requires afterload reduction or pulmonary vascular resistance reduction, and all of that. But then you will always need a human to understand what exactly is going on, interpret this data. So there will still always be a human component behind it. And remember, to say that the PA catheter alone can save a patient is a little far-fetched. It's not a single data point or a set of data points, but it's a compendium of factors. We just don't solely depend on the PA catheter. We have other, monitoring points. We have echo. We have, lactates. We have gases. To better understand it. But I just say that when it comes to monitoring of these patients, we need a collection of data points, and not just single data point, and not just a single device. All right, that ends my talk. Thank you.
Thank you, Varun Shetty. That was a wonderful presentation. You
Thank
have
you.
given a nutshell of the utility of pulmonary artery catheter despite its declining use. You mentioned about pulmonary endarterectomy, how important it is in transplants, LVADs, mechanical support devices, etc. Very well done. And if there are any questions, please feel free to ask Dr. Varun Shetty. You can either put it on the chat box or you can unmute yourself and ask the speaker directly. To set the ball rolling, Varun, did you have any complications because of PA catheters? In your wide experience, you do so many complex cases. Every second patient, I think, gets a PA catheter in your OR.
Yes.
Did you have any complications attributable to pulmonary artery catheter?
To be honest, whatever are the reported complications, I honestly have not seen any. Whether it's pulmonary artery rupture or any of those devastating complications, I think it's an overstated complication from my experience. But maybe fortunately, I haven't encountered any of those due to the direct use of the PA catheter. I only can speak about the benefits from it.
That's right. I agree with you. Actually, we have analyzed 1,000 PA catheter insertions, and excepting for transient arrhythmias, we did not have any major issue with the use of PA catheters.
Yes.
Any comments and questions from the audience? Anup is there, Anup?
Yes, sir. I'm here.
Do you want to comment or say something on this?
Sir, there is one question from Dr. Jagdish, sir.
Yes. Dr. Jagdish, yes. Please read it out.
What about flow track catheter compared to CCO? That is what he is asking.
Varun, do you want to answer that? Flow track?
No, I actually have no experience in using flow track because we are so the CCO is so integral in our management and decision making that we just have not looked any other way. So I'm sorry, I won't be able to answer that question well enough.
I agree with you. Flow track does not give the PA pressure. It's a cardiac output derived from pulse contour using a specialized transducer, which is company proprietary. So the thing is, flow track is reasonable when the patient is stable, but we are not sure whether it gives accurate readings when the patient is unstable. Whereas pulmonary artery catheter is the gold standard, and all the other devices are compared to pulmonary artery catheter when it comes to cardiac output measurement. So pulmonary artery catheter has an important place in the management of complex cases, and flow track may not be the preferred equipment in difficult cases and complex procedures. Jagdish, you can unmute.
Yeah, I can unmute now.
Yeah, you can unmute and you can comment.
Yeah, Dr. Muralidhar.
Yes.
Good, Varun, good presentation.
Thank
I know
you.
this flow track cannot replace the PSC because the pulmonary artery pressure is what we are looking at in these cases.
Correct.
Definitely.
Yes.
Yeah, I agree.
Correct.
And without the pulmonary artery pressure, there is no starting point. Everything starts off with the pulmonary artery pressure, and then after that, the rest follows. The rest of the treatment follows.
I am also a fan of PA catheter, thousands,
Yeah.
and I like it. But I just wanted to convey the information. The flow track does give CCO, but it doesn't measure the PA catheter, so that is only disadvantage. Yes.
And also, when you want to choose a vasoconstrictor versus inotrope, the systemic vascular resistance and pulmonary vascular resistance derived from the pulmonary artery catheter will be useful.
That's true.
This information, especially PVR, will be lacking in the flow track.
Yeah, sure.
Anup, you were starting to say something?
No, sir. So basically, Dr. Jagdish had already clarified about the importance of PA catheter. So flow track has its role not in cardiac surgery. So flow track, there are a lot of limitations in using flow track. So primarily, we have to start off with a good arterial trace. So even when the arterial trace is not good, the whatever value is displayed by that catheter and by that monitor is flawed.
Yes.
And then secondly, in a patient with large volume shifts and frequent changes in the SVR, flow track values are not at all reliable because there is no calibration of that values that are derived. And also the cardiac output that is displayed by the flow track catheter is only calculated value. It is not directly measured. It is measured using the proprietary software from the company.
Yes.
So it's not directly measured. So for a direct measurement of a cardiac output or cardiac index, we have to depend on the PA catheter only. And there are several other advantages of using a PA catheter, especially for the kind of patients that we deal with in open heart surgery, where there and also not just for mechanical support or transplants, even in complex cardiac surgery patients, PA catheter has established itself as a definite and indispensable part of monitoring. And as Dr. Varun has rightly pointed out, just because we put in a PA catheter, that doesn't mean the patient is going to survive. It is you cannot compare outcome just because you put in a PA catheter. You have to use the data.
Right.
And at the beginning of his talk, also he had pointed out that PA catheter data is highly underutilized. We don't use all the data that the PA catheter is deriving. So when we, as a clinician, if we are not able to use the PA catheter to its fullest extent, the fault lies with us, not with the PA catheter. There's no point blaming the PA catheter for that.
You are right. I agree with what all you said. Thank you, Anup. Anybody else wants to comment or question on this topic of PA catheter use in cardiac surgery? Srinivas is there? Srinivas? Anybody else? Shraddha, you want to say something?
So I think Dr. Anup has summarized it pretty well.
Right. Dr. Mahala? If you are given only one choice, whether you want to use PA catheter or echocardiography, what will you use?
This question is to me.
Maybe you can answer it, but it can be answered by anybody else.
I don't like to comment on this because that is your topic. You can pass the comment.
Yeah, no, I don't think only one. I think both are extremely important because as we said that sometimes the PA catheter can be wrong and we don't understand what is happening, and then the echo is extremely important part.
Right.
And also, let's not forget the cardiac index takes time to compute between B to B, but with the echo, it's fairly straightforward. You know exactly what's happening inside the heart.
Right. Yes, I agree with you. Both are complementary. PA catheter and echocardiography, both are complementary. Probably both should be used in complex, difficult cases and to get the best out of the both. That should be the strategy, I think so.
And so we also use echo guidance to float the catheter sometimes.
Right. So they are complementary. They help each other. We get the comprehensive information about what's happening with the patient if you use both the techniques. The problem with the echo is that it is not continuous, except when you are using the hemodynamic TE, which is not available in India. Otherwise, it is we don't get continuous information, whereas pulmonary artery catheter, we get almost a continuous information. With that, can I close this and go on to the case discussions? Anybody else wants to say anything else?
I think that's okay. That's fine.
Thank you, Varun. Thank you for joining us. And we'll go on
Welcome,
to the case scenarios. Well done. Case scenarios. First case will be dealt with Anup Daniel Varghese. He is going to discuss out the case. And feel free to comment or participate in the discussion, ask questions. This case will be discussed for about 40 minutes. I'm starting the timer now. Please, Anup is a critical care specialist who works in cardiac unit in Narayana Vidyalaya. We're very upright and academic in his approach. Dr. Anup Varghese, can you please start the discussion?
Yes, sir. Thank you, sir. And thank you. I thank the organizers for giving me this opportunity to be a part of this an academic program. And today, let me give full justice to the job that I have been entrusted with. So initially, in the first part of our meeting, we had a beautiful lecture from Dr. Varun, who highlighted the importance of PA catheter in cardiac surgery. Of course, and for the very much complex cases like mechanical support, transplants and all, the use of PA catheter is undisputed. But what about in routine cardiac surgery patients? Will you consider using a PA catheter in a routine cardiac surgery patient following a CABG or a valve, something like that? Okay. So instead of bombarding you with a lot of data or the theory and previous studies, let us go through a case that we had in our ITU. And so I'll start off with the case, and you can help me out in, let's make it an interactive session, and you can help me out in saying what you think would be the right approach for in a step-by-step manner. So starting off, to give you an idea about what the patient is. So this was a 65-year-old gentleman with a history of diabetes and hypertension for the last 20 years. He presented to us with complaints of central chest pain of 15 days duration associated with shortness of breath. There was fatigue also for 1 month duration preceding the chest pain. He came to our ITU. No, sorry, not to the ITU. He came to our emergency department, where he was diagnosed to have coronary artery disease with triple vessel disease and a critical left main disease. An echo was done that showed normal chamber dimensions, ejection fraction of 45%, normal RV function with a TAPSE of 17, trivial to mild AR and MR, moderate TR, and a diastolic dysfunction as diagnosed with E by E prime of 14, E by A of 0.6, and a PS systolic pressure of 64 millimeters of mercury. There was a region of wall motion abnormalities, particularly at the apex, mid anteroseptum, basal infroseptum, and the basal inferior wall. An HRCT was also done as part of our institutional protocol because of this current pandemic situation that is going on. And that found that the patient had subsegmental atelectasis in bilateral basal areas. And there was peribronchial consolidation in the right lower lobe. An RT-PCR was done, and which was found to be negative. And he was also incidentally found to have IgG reactive, although he does not know of any history of COVID infection previously, and he has not received the vaccine as well. So he was admitted in the ward and posted for CABG surgery. But unfortunately, he developed acute shortness of breath associated with chest pain in the ward. So he was shifted to our ITU with oxygen of 4 liters per minute. And coming to ITU, he had a heart rate of 96 per minute, blood pressures of 140 by 76, and a saturation of 97% on 6 liters of oxygen. He was started on heparin infusion and GTN infusions. Last 6 boluses were given, and he was connected to NIV through with 50% oxygen. And with this acute management, he settled down. And then he was taken up for surgery the next day. During surgery, standard monitors as per the ASA recommendations were attached, and he was pre-medicated with midazolam. But during induction, he went into acute pulmonary edema and had a severe hypotension at that time. So therefore, an IABP was inserted. Looking at his, based on his angiogram findings and his clinical picture, the surgical team decided to do a vein graft to the left anterior descending artery. And he had severe hypotension during grafting. And noradrenaline was started and gradually escalated to 0.08 mics per kg per minute. Due to the high vasoconstrictor requirement and the overall picture that was there in the intraoperative period, a PA catheter was inserted before shifting the patient to the ITU. So we received the patient in the ITU with an IABP in situ and a PA catheter in situ. The patient was receiving noradrenaline at 0.08 mics per kg per minute. So this is the scenario now. So let us have a look at the vital signs when the patient comes to the ITU. Rakesh, shall I stop screen sharing now?
Yeah, please stop sharing.
So the case is open for you. Do you have want any more information on this case? Anybody wants to know anything more on this case? Diabetic, hypertensive, central chest pain, 15 days. EF is 45, mild ER. Heart rate is 96. PA systolic pressure is 64. There were regional wall motion abnormalities on the echocardiography.
So now,
one graft was done.
okay. So now we'll see the vital signs after the patient comes to the ITU and when the vital signs monitor was connected to the patient in that ITU.
I'm sharing, sir.
Okay.
Are you able to see, sir?
Yeah, you can see we can remove the hemosphere from there now. Yeah, right. So these are the parameters when the patient comes to the ITU. So we got a heart rate of 110 per minute. It's sinus rhythm. The pressures on arrival in the ITU was 84/40 with a mean of around 59. PA pressures were around 40/22 with a CVP of 14. Saturating is 99%. The patient is on mechanical ventilation. At this stage, what do you think we should do? What should be our next step in management? And the patient is already on 0.08 mics per kg per minute of noradrenaline. Feel free to unmute yourself and answer, or you can even put your comments in the chat box.
There is a question on TEG intraoperatively.
Yeah. So the patient, we had not done a TE in the theater. Any comments or any suggestions? What should we do?
This patient is undergone surgery. Only one graft, is it?
They have done only one graft, sir. Yes.
One graft. Okay. Okay.
Yeah. Yeah.
I think fluid is not the answer because the PA pressure was also high and CVP is also high.
Yes. Right. So the most common, let's see what the most common things are common. So whenever a patient comes back from the theater, the first step for us would be, because the patient had been under anesthetic, a lot of sedation had gone on. So vasodilation or fluid hypovolemia is a concern for us. So initial our attempts would be always to give a little bit of fluid and see how the patient would respond. So let's see what happens if we give a 250 ml of crystalloid to the patient.
Given, sir.
Right. So we given 250 ml of crystalloid. There was marginal improvement in the hemodynamic parameters. So the systolic pressure went from 84 to 88. Not much of difference in the PA pressures. The heart rate also has remained unchanged. CVP also marginally it has climbed up. So that's the situation where we are in now. We are nowhere near stability. So, and there's another comment from Dr. Merlin Shalini. We have to give dopamine and increase NORAD or adrenaline, right? So that's a good suggestion. So in a patient with already having a lower pressure, would we consider giving inodilator at this point? I don't think so. So that again can bring the pressures down even further. So either the vitamin has a tendency to produce vasodilatation, and with a low BP, that may not be a good idea. Increasing NORAD, yes, that is an option. The patient is already on 0.0 mics per kg per minute. So if there is option of, because you know the range is 0.02 to 0.2. So you can increase the dose of noradrenaline and we can see what is the response. Alternatively, we can also add adrenaline. So from the response itself, we know there are 3 drugs that are mentioned and we don't know what is the right answer. So we have to do a little bit of dilly-dallying, see which one works, and then try do a trial and error method and then come up with a solution. Do you really want to do a trial and error method and play around with drugs when a patient is critically ill, what if we can get accurate information and which will tell us what to do next? Manoj, can you pull up the Hemosphere screen? So remember, the patient had a PA catheter and we have hooked up the PA catheter as a monitor. Let's do a complete continuous cardiac output for the patient and see what is the value. So here, when you see with these vital signs, and when you connect the cardiac output monitor to the patient, you see that the index is 2.9 and the SVR is 677. So when you have this additional information along with the vital parameters, the answer is clear. You know what you have to do. Yes, as Dr. Shalini has said, yes, you can increase the noradrenaline, or the alternative approach would be to add a second vasoconstrictor so that the overall dose or the total dose of one agent can be reduced. So recent guidelines all support that. Instead of increasing the dose of noradrenaline, then inviting the adverse effects of noradrenaline, you can add a second dose of a vasoconstrictor to the mix and see what the response is. So that's what we did with this cardiac output data. So we added vasopressin on to the patient, and let's see what happened to the patient after starting vasopressin. Manoj, there you go. So after starting vasopressin, there was a slight decrease in the heart rate, and the pressures are also picked up. So now we have a systolic pressure of 110/71 and a mean of 86. PA pressures also have gone up slightly, 45/23, and CVP has come down slightly to 12. I feel these are a decent amount of decent parameters to go by. So the patient continued on 0.08 mics of noradrenaline and 0.003 units of vasopressin. And that's how the patient was going. The patient was relatively stable, hemodynamic parameters were maintained. But after 1 hour, there was again a change in the hemodynamic parameters. Let's see what happened after 1 hour. Manoj?
Yes, sir. Give me.
Anu,
yes, sir.
Can I ask one question? See, before you connected the patient to this hemodynamic monitor,
yes, sir.
We had the PA catheter.
Okay.
CVP was 14, pressure was 80.
Yes.
So can you also consider cardiac tamponade, early tamponade or something like that? Because
yes, sir.
CVP is little higher, pressure is lower. We need to know what is happening with the peripheral temperature and the urine output.
Yes.
So because you already connected to this monitor, you had a SVR of low
yes, sir.
500 or so. 600.
Right, right.
So you concluded that the vasodilatation and treated with vasopressin and got good results.
Yes, sir. So most of our patients following cardiac surgery, when they come in from theater immediately, they already have a mediastinal tube.
Yeah.
And so the mediastinal tube will be draining fluid, whatever is collecting in the pericardial space. So very, very unlikely immediately after coming from theater that the tubes will be blocked. So yes, you really did raise a very good point. It can be tamponade, definitely, that we have to keep it in the back of our mind. But that would not come as the first diagnosis immediately after coming from. Definitely a few hours down the line, definitely that is one diagnosis that we have to consider, especially with a low pressures and a high CVP.
Right, right, right. Was there any acidosis that time, or it improved after vasopressin?
No, immediately after coming back from theater, yes, there was an base excess of around -4, -5. And gradually, after giving some fluid and starting vasopressin, the acidosis also settled down. The lactate was not, however, it was not elevated. It was in the range of 2 to 3.
Okay. Please carry on. Please carry on.
Yes, yeah. So these were the Hemosphere. You can see the changes that have happened. The index has come to 1.9 and the SVR had gone up to 1700. After 1 hour, these are the parameters that you are seeing. So the heart rate went up to 125. there was a significant hypotension. PA pressures had gone up to 50 by 28, and a CVP also shot up to 24. So these are the parameters that you're seeing after 1 hour of coming into the ITU. So at this stage, as Sir had rightly pointed out, definitely cardiac tamponade is something that you should consider and keep in your mind. And we have to, when you are suspecting cardiac tamponade, you have to get an urgent echo and rule out what is happening to rule out tamponade. What are the other causes that can lead to a picture like this?
Participants, please feel free to express yourself.
Right. So, and if you look at the hemisphere monitors as well, you can see that the index is around 1.9, and with the change in the vital sign parameters, the SVR is around 1000, with a stroke volume around 74 ml per beat. Yes, Dr. Merlin has replied, RV dysfunction. Yeah. Yes, that's a very good suggestion. Yes, definitely. That is something that we have to strongly consider in a patient following cardiac surgery. RV dysfunction is a very common cause for a picture like this. And our PA catheter data also kind of supports that scenario. So in this kind of a scenario, what would you suggest that we should do next? So the index is 1.9, which is on the lower end, and the SVR is 1059, although it's not very low as when he came in from theater, but definitely slightly on the lower side. So what do you think we can do to improve RV dysfunction at this stage? Definitely, there is no doubt that the patient needs inotropic support. Yes, so Dr. Merlin has replied, Milrinone. So in a patient with hypotension, do you think it is safe to give a inodilator? We all know that the adverse effect of giving inodilators, which includes both dobutamine and Milrinone, is hypotension. So in a patient who is having hypotension, would it be a wise choice to use an inodilator? Or can we use something else in the interim till the numbers get better? Right. So I'll just say what we did when we were faced with this patient. So at this stage, the patient was already on NORAD and vasopressin, and the index had come down to 1.9, and the SVR also slightly on the lower side with the hypotension. So what we did was we started adrenaline for this patient. So we started 0.04 mics per kg per minute of adrenaline, and let's see what happened to the vital signs after starting adrenaline. There you go. So this is what we did. We started adrenaline for the patient, and there was a slight decrease in the heart rate. The heart rate came down to around 110. The pressures also significantly improved to 130 by 60 with a mean of around 88. PA pressures was slightly on the higher side still, 50 by 24. And the CVP also had come down from 24 to 17. So this is what we did. And let's see what happened to the hemisphere values also. Always whenever you have to remember that whenever you have a PA catheter, although it says continuous cardiac output, there is always a time lag between the PA catheter values or the cardiac output values on the hemisphere compared to the vital signs. So you will not immediately see the changes in the reflect changes on the hemisphere with the changes in the vital signs. You will have to wait for a few seconds for the calculations to be done by the monitor, and then only then you will be able to appreciate the changes on the hemisphere. So after starting adrenaline, there was a definite improvement in the vital signs. The hemodynamics were pretty good. And let's see what happened to the hemisphere or PA catheter or cardiac output values. So you can see here that The index, there was not much of a change. It's still at 1.9 liters, but SVR has significantly gone up to 1,695. So let us assume a scenario. We had started adrenaline, the patient's already on noradrenaline and vasopressin, and we are faced with these values. And suppose we did not have a PA catheter at that phase. What would be our logical solution? We would assume that the patient is hemodynamically stable and we would continue with the supports. But because we had the PA catheter in place, we were able to appreciate that the index was still on the lower end. The patient was not getting enough cardiac output to meet his metabolic needs. So just by looking at the vital signs of our systolic pressure of 130/60 doesn't mean that the patient is hemodynamically stable. We have to, so maintaining a number on the monitor is not our goal when we are managing patients with respect to vital signs or hemodynamic parameters. Our goal is to maintain perfusion. We have to ensure that there is adequate blood flow reaching the vital organs. And with the PA catheter, we were able to diagnose that the patient was not receiving enough cardiac output, or the index was only around 1.9. So can you suggest what we can do in the next phase? We have an ISVR, the index is only 1.9, and the hemodynamic parameter, vital signs are pretty much stable. So at this phase, what can we do? Any suggestions?
Can you reduce the peripheral vasoconstriction?
Yes, very good. That's very good. So we have, the SVR is very high and it is not in the normal range. So our next option would be to reduce the peripheral vascular resistance. How can we do that? We've got NORAD and vasopressin going on. We can reduce, and the NORAD is at a pretty high dose. So we can try to come down on the noradrenaline dose and see what happens to the patient. So Manoj, can you reduce the noradrenaline, please?
Yes.
So the NORAD was going as 0.08. Let's reduce it to around 0.06 and see what happens to the patient. Yes, there are a few changes coming in. Right. So we reduce the noradrenaline slightly, and you can see that there was a reduction in the systolic pressure. The systolic pressure came to 100/50. Not much change in the PA pressures, and the CVP is also more or less at the same rate. Heart rate is around 110. An index marginal, very, very marginal, from 1.9 to 2 liters per minute per meter squared. And SVR also slightly, it has come down. So what would be our next logical step? We can try again reducing the vasoconstrictor again, but then we have to understand that by reducing the noradrenaline from 0.08 to 0.06, there was a reduction in the systolic pressure. So would we attempt to reduce the vasoconstrictor even further? Or
difficult, just reduce the vasopressin.
Reduce the vasopressin.
Vasopressin, yeah.
Yes, yes. So Manoj, can we reduce the vasopressin then? Yeah, so the changes for reduction of the NORAD was still reflecting. We've got an index of 2. The SVR has come down to 1,211. So these are the changes of the NORAD reduction itself.
Okay. Index is still not improving.
Index is still not improving. There's not much of changes in the vital signs also. Yes, Dr. Merlin is suggesting IABP. Remember, in our initial case presentation itself, the patient had come to the ITU with an IABP. So the IABP is already in situ. There you go. So then again, the SVR, you can, if you notice the hemisphere, the SVR has come down even further. There's a slight improvement in the pressures. The SVR has come to 1168. And the PA pressures also have come down to 45/23. an index, but there's not been much of a change in the index. The index is still stuck at 2. So what can we do to improve the index for this patient? The patient is already on adrenaline. We have tried reducing the vasoconstrictor, but not much of improvement in the index. Is there anything else? And definitely, as Dr. Shalini had previously commented, yes, definitely the patient is having RV dysfunction. Is there anything else that we can try to improve RV function? Let me suggest something. So what we did for our patient was we started dobutamine for this patient. And let's see what happened when we started dobutamine for this patient. Manoj?
Yes, sir. Giving, sir.
Yeah.
Your nursing staff is very efficient. Whatever is needed, they do it very quickly.
Yes, sir. So we have a very efficient team, sir. So because they have to respond immediately to changes that happen to the patient.
Correct.
That's how we deliver good results.
Yeah, I compliment you for that.
So we started dobutamine for this patient and continued with the adrenaline and the NORAD and the vasopressin. IABP was already in situ when they came from theater. And after starting dobutamine, this is the result that we noticed. There was a significant improvement in the systolic pressure from 120 to 125 by 57, mean of 85. Pre-air pressure also stabilized at 50 by 23. CVP was around 14, not much of a change in that one. But if you look at the hemisphere parameters, there has been a significant improvement in the cardiac index. An index which was around 2 improved to 3.1 liters per minute per meter square. And SVR also from the high 1500s, it had come down to around 1000 range. So that was the value, that was the change that we see. So if we look at these parameters of them, vital signs look pretty good. And also the SVR also is good. But what is more important is the perfusion for the patient. The patient, the heart was able to produce 3.1 liters per minute per meter square. All our management, what we have to concentrate on is to provide good perfusion to the end organs or vital organs. So that is our primary objective. All the static parameters or the blood pressures or the PA pressure which we are using, they are only static parameters. They only give us a clue. We assume that our perfusion parameters will be corrected if we get a good static parameter. But if we use a PA catheter, we always will be able to diagnose these borderline cases. So that is what I just wanted to highlight through this case. So definitely, we were able to manage accurately this patient only because with the help of a PA catheter. So now the patient was on adrenaline and dobutamine. That's how we were able to achieve these parameters. And these were the vital signs that we were able to achieve for the patient. Gradually, we continued the patient on these vital parameters. The patient improved, perfusion parameters improved, the end organ perfusion improved, the acidosis settled down, the lactate also, which was in the 2 to 3 range, also settled down, and we were able to successfully extubate the patient. Following that, the IABP continued, and gradually we tapered down the NORAD and the vasopressin based on the SVR values and the index values. We constantly monitored the cardiac output and the cardiac index, titrated the vasoconstrictors based on the SVR values, and also looking at the vital signs as well. So after 24 hours, let's see what was the vital sign parameters. Manoj? Right, so these were the values. So you can see that the tachycardia is significantly getting better. The systolic pressures are also improving. The PA pressures more or less has been at the same level, and CVP is around 14. At this point, I just like to emphasize on another part. If you would recollect the initial HRCT of the patient had bilateral atelectasis of the chest, and also there was some amount of consolidation around the right bronchus. So you can see that itself, the lung parameter can contribute to a raised PVR. And that is what is reflected on the higher PA pressures that you are noticing over here. But normally, if you have good vital signs or good cardiac function, you should not see such high PA pressures. but the high PA pressure in this patient was due to the lung factors. It's not due to the heart. So that's another point that I wanted to stress out in this presentation. So going forward, after 24 hours, the vasoconstrictors were gradually tapered off. And with these parameters, with an index of around 3 and SVR 1236, what do you think would be our next logical step to do? So in the interest of time, I'll say what we did. We gradually weaned off the adrenaline as well, and they left the patient only on dobutamine.
Correct.
Manoj,
That's right.
can you show us the screen of where we had only dobutamine for the patient?
Yes, sir.
The IABV still continued after extubation as well for 24 hours. And yes, these were the parameters when the patient was only on dobutamine. So that remained, the balloon remained for 48 hours. And after 48 hours, the balloon was also taken off. The patient remained only on dobutamine. And these are the vital sign parameters for the patient with dobutamine alone. You can see the heart rate is around 80. The systolic pressures are 130/70, which is also acceptable. PA pressures also came down 48/20. And at this stage, we also aggressively treated the patient's bilateral atelectasis. We gave NIV, improved the lung function, encouraged incentive spirometry, tried to recruit the lung, mobilized the patient, and encouraged walking and the other exercises as well. All that helped us in improve and recruit the lung. The lung condition also improved, and that is what you are seeing reflected in the PA pressures. Following after 3 days, Manoj, can you see us? Show us the off dobutamine stage.
Sure.
And then after 3 days, we gradually weaned off the dobutamine. And so in our management of our patient, along with PA catheter, as Dr. Murli had initially pointed out, echo, that is also an integral part in the evaluation of the patient. We used to do daily transthoracic echo for the patient and evaluated the cardiac function of the patient. And we correlated the cardiac function with the PA catheter findings as well. And based on that, we made decisions for how to use our inotropes, how to taper the inotropes, and assess the cardiac function. In the next slide, I will show you what was the echo findings in the post-operative period. So this is our last screen.
Yes, sir.
No, this is not the one. Off dobutamine.
Not.
You have gone back.
Given, sir.
$300, Manoj? Systolic pressure of 300?
Somebody's flushing, I think.
Somebody's flushed. I should take back that comment about your nurses now.
Hey, please. It is a momentary. It is momentary. It's okay.
Yes, so no, zeroing of the lines is also a very important procedure that we do in our ITU, sir.
Okay.
Right. So this is the vital signs after 3 days, where we weaned off the patient from all the inotropic supports. So we have a heart rate of around 75-76 per minute, a systolic pressure 127/68. The PA pressures were slightly on the higher side, 50/26, but the CVP definitely had come down to 8 and a saturation of 99%. That was off the ventilator. The patient was on 4 to 6 liters of oxygen at that time. Right. So that was, and at the same time, let me just show you what was the echo finding. So Manoj, can you stop sharing?
Yes, sir. Yes, sir.
So in the post-operative period, we did an echo for the patient. We used to do daily echoes, but this is the echo after the dobutamine was weaned off. So it showed an LV ejection fraction of 45%. We routinely monitor LVOT VTI. So that's how we assess the LV cardiac systolic function. The LVOT VTI was 15.6. TAPSE was slightly on the lower side, 13, which indicates mildly impaired RV function. There was mild MR, mild to moderate TR, no AR. The region wall motion abnormalities were present as in the preoperative period, but there was no new region wall motion abnormalities, and there was no pericardial or pleural collections at that time. So as part of our discussion, what do you mean by, so this case I wanted to present to the community just to have an, just to highlight that patients coming to our ITU following cardiac surgery, they may not come in the pure vasoplegic shock or a pure cardiogenic shock. What do you mean by vasoplegia? So vasoplegia is a condition that is characterized by normal or augmented cardiac output with a low SVR and low enough to produce organ hypoperfusion. There is no universally accepted definition for vasoplegia, but most studies that analyze or study on vasoplegic shock use this one as the accepted definition. So in vasoplegia, you need to have an index of more than 2.2 liters per kg per minute and an SVR of less than 800 dynes per seconds per centimeter. The incidence is estimated to be around 5%, but mortality is for patients with vasoplegia is roughly estimated to be around 50%. That itself indicates how serious this condition is. And the causes for vasoplegia could be CPB-induced release of pro-inflammatory cytokines, stimulation of the locus coeruleus and the hypothalamic pituitary adrenal axis by the inflammatory cytokines, leading to overproduction of nitric oxide and depletion of noradrenaline and vasopressin endogenous stores. I would recommend all interested candidates to read this interesting article where recently came out last year, where the pathophysiology of vasoplegia and the of vasoplegic shock is beautifully elucidated in that one. Treatment, there is no doubt, once you diagnose vasoplegia, the treatment of vasoplegia is definitely using vasoconstrictors. It's either noradrenaline or you can add vasopressin as well. But the important point is to diagnose vasoplegia. All causes for hypotension is not vasoplegic due to vasodilatation. In cardiac surgery particularly, it can also be due to cardiogenic shock. So what is cardiogenic shock? It is hypotension and hypoperfusion due to an inability of the heart to produce adequate cardiac output. So it is diagnosed by systolic pressure less than 90, end organ hypoperfusion, which is characterized by alternate maintenance states, closed extremities and oliguria, or biochemically by a lactate more than 2, an index if you have a PA catheter less than 2.2 liters per minute per meter squared. So in our case, to summarize, we were faced with a scenario where the patient came initially with vasodilatation and associated with some element of cardiogenic shock as well. So that's the reason why we had to use a vasoconstrictor along with an inotrope agent to achieve a good outcome. So with that, I'll end my show. And
very
I'll
nice
open the forum to leave the comments.
Yeah, thank you, Varghese. Very nice presentation with nice management also.
Thank you, sir. Thank you very
Very
much.
nice. I have two questions. One is, what was the temperature, peripheral temperature of the patient during that period of shock?
Yes. So all our patients who come from theater, especially when they have a balloon, we measure the peripheral temperature as well. The peripheral temperature was in the range of 25 to 26 degrees. Whereas we also measure the axillary temperature for that patient. We try to avoid using nasopharyngeal probe because we had a few adverse events in the ITU. So with that, we have stopped using nasopharyngeal probes, but we use an axillary probe and we use the temperature gradient between that to diagnose hypoperfusion. But it is not very reliable, but it gives us an indication or an early marker.
What happens to temperature in vasoplegia? Peripheral temperature?
Peripheral temperature. So peripheral temperature, there is not much of a difference between the central and the peripheral temperature in vasoplegia, or you will have a higher temperature in the peripheries.
Correct, because in low cardiac output, we find cold peripheries.
Correct. Yes.
That's a
So, but in
difference.
our patient, it was not a pure vasoplegic shock. So that is what
Correct.
I want to stress, because particularly in medical intensive care patients, you will see pure vasoplegia following sepsis or ARDS. But in cardiac surgery, there will be some amount of element of cardiogenic shock also disguised under vasoplegia. So that is something that we have to keep in mind. And to diagnose that, we will have to use PA catheter. Otherwise, that cardiogenic shock which is underlying will not be unmasked. So that is the point I just wanted to.
Okay. One
Yes,
more
sir.
question, can I ask you?
Yes, sure, definitely, sir.
And what happened to the patient for the further management, because he was undergrafted? So what is the plan?
Yes. So to be frank, my role comes in once the patient comes in through the door after surgery. And once,
No, it's just for academic interest.
yes. So the patient, this patient was stabilized and he was discharged from our unit. He went to the ward, recovered from that one, and he will be called for a review after 6 weeks, where he will be reevaluated and see what can be done.
Maybe
But
angioplasty or
findings were that the other vessels were too tiny, so it was not graftable.
Okay, maybe angioplasty if it is required or possible.
Yeah, so because the patient initially came because the vessels were not plastiable. So that's how they came to us. So, and they had an acute episode of MI also at that time. So that's why we went in for surgery urgently. So once the acute episode settles down, probably he will be called in for another reevaluation, and then we'll have to have a relook and see what best can be done for the patient.
What was the EF on discharge?
45%, sir.
Okay. All right, Varghese. Thank you.
Thanks, sir. Thank you.
Very nice.
Thank you, Anup, for that excellent discussion on a case who had vasoplegia probably, followed by RV failure and with increased PA pressure efficiently managed.
Thank you, sir. It was
any last question? Otherwise, we are going to go to the next case. Thank you, Anup, for that excellent discussion.
Thank you, sir. Thank you.
Thank you so much. May I invite Dr. Mahala now to present an unusual complication following CABG, which posed a diagnostic dilemma in the post-operative, 3-4 months after surgery. Dr. Mahala.
Good evening. Yeah. Good evening, ladies and gentlemen.
Dr. Mahala is a prolific speaker and very well-known cardiologist, and we value him for his clinical acumen.
Thank you, Dr. Muralidhar.
Thank you.
Good evening to you all. We have very, very interesting case now, and I'll request Dr. Kedar to present the case.
Yes, a very good evening, everyone. Thank you for providing me this platform to present the case. I'm sharing the screen now. So very good evening, everyone. Now hereby I present a case which proved a dilemma, which was an interesting dilemma. And that was the situation after coronary artery bypass grafting surgery. So the case is of a 61-year-old male patient who came with the complaints of angina, dyspnea on exertion. He had diabetes mellitus and hypertension as comorbidities. This situation is of March 2020 when coronary angiogram was done. It showed a left anterior descending artery involvement of 80%, left circumflex 50%, with ostial region of major diagonal of 50%, obtuse marginal 50%, and RCA 60%, with further branches of PDA 70%. So his impression was double vessel disease. He underwent left thoracotomy coronary artery bypass graft surgery on 16th March 2020 and was discharged uneventfully. This is the angiography image. On the right side, we see the RCA, and the left side, we see the left main and its branches. So the patient now, 8 months later, he develops breathlessness complaints and he reports again to the hospital by November 2020. On echocardiography, his ejection fraction was 55%. There was no RWMA, that is regional wall motion abnormalities. There were mild mitral and tricuspid regurgitations, and PA pressure was increased. Normal RV function. So cardiac MRI was done at the same time. There was circumferential pericardial thickening present. Interventricular septum bulged towards the LV during inspiration, and systolic function was maintained. So at the same time, CT scan of chest showed moderate pleural effusion. Gallbladder calculus, a small one was present of 7 millimeters, and there was no gross abnormality. Ultrasound of abdomen showed some coarse mild changes in the ecotexture of the liver with mild pleural effusion, and hepatosplenomegaly was present with mild ascites. He underwent intercostal drainage tube insertion of both sides, and ICD was in situ for a few days till 24th November in the same month, like 7-8 days in the year of 2020. Pleural effusion was drained. After that, the patient was again discharged in stable condition. Now at present, he again has come with the chief complaints of breathlessness on exertion, which was progressive. It started 6 months ago. And along with that, there is abdominal distension accompanying that. That was started since last 5 months. There was generalized swelling of both legs and face since last 3 months, and swelling in the scrotal region since last 3 months. There was no history of cough, fever, chest pain, yellowish discoloration of skin, hematemesis, melena, clay-colored stools, hematuria, cola-colored urine. In the past, patient has had CABG, and otherwise there is no medical or surgical history. He doesn't consume alcohol, cigarette, and has a mixed diet. On general examination, there was no obvious abnormality. On inspection, there was pedal edema, facial puffiness, and visible jugular venous pulsations. Abdominal system revealed that there was distension, inguinal scrotal swelling. The swelling didn't enlarge with cough and was not reducible also. There was no use of accessory muscles of respiration. There were no dilated veins on the skin of the abdomen. On palpation and percussion, there was horseshoe dullness, shifting dullness, and it was possible to get above the swelling in the scrotal region. Hepatosplenomegaly was present. Then in the respiratory system, there was dull note on bilateral inframammary regions. On auscultation, these findings are confirmed. There was decreased air entry in the bilateral lower lung regions. Crepitations present bilaterally, no wheeze and rhonchi. Both heart sounds were audible and there were no obvious murmurs. So now we reach a differential diagnosis. There are 3 things that flash in my mind. So first thing, as we are ruling out many other findings, first thing I think about is some cardiac origin for this condition. So what I can think about is a filling defect which occurs in constrictive pericarditis, which is very much possible after the CABG surgery. Another reason which we think about is liver origin, which can be a liver parenchymal disease since there is organomegaly. And another thing is again protein-losing gastroenteropathy. So this is the ECG of the patient. Now we are moving to investigations. So this ECG revealed a right axis deviation. There was a regular rate, sinus rhythm, and no other gross abnormalities. Coming to lab investigations, they were all within normal limits except N-terminal pro-BNP levels were raised according to the age. And there was hypoproteinemia. When we evaluated him for transthoracic echo, the total bilirubin, we are still in the lab reports in this, total bilirubin and serum transaminases are also worth mentioning. They were within normal limits. Serum creatinine level was also within normal limits. Now coming to echo, his ejection fraction was 60%. There were normal chamber dimensions, normal valves and no regional wall motion abnormalities. There was no pericardial effusion. E/A ratio was 1.1. Septal bounce was noted. TAPC was good. 4 mm pericardial effusion was found near right atrium. There was no evidence of tamponade. Inferior vena cava dilation and non-collapsibility were not opined about in detail. So moving to transesophageal echo. Now we decided to do one transesophageal echo for this patient since we needed to evaluate about the cardiac condition which we are thinking about in the first DD. So TEE revealed spontaneous echo contrast, dilated LA and RA, and reduced internal diameters of LV and RV with restricted filling. The E and A waveform were suggestive of pseudo-normalization, diastolic and diastolic dysfunction. E/A ratio was 1.55. Doppler tissue imaging and Doppler of mitral valve also revealed the same. Medial E prime velocity was 10 centimeters and lateral E prime was 8 centimeters per second. So medial tissue Doppler imaging velocity was more than the lateral, which is the hallmark of constrictive pericarditis. It is called as annulus reversus. The IVC was non-collapsible. Pulmonary vein waveform, however, was not showing any change. So these are the physical images of the patient. There is generalized edema starting from the feet and also in the inguinoscrotal region. He also had ascites. So this is the midesophageal 4-chamber view. There is spontaneous echo-contrast here. Bilaterally we can appreciate. This in RA, there's some structure. Maybe it's a pectinate mesh muscle. There was not much found about it. Pericardial effusion can be appreciated here. There's thickening of the pericardial wall, which is appreciated here. There is restricted filling of both ventricles. With each opening of the tricuspid valve, the septum bounces towards the LV. So this is the transgastric basal short axis view of TEE. With the septum is here in between. It can be seen moving towards the LV as and when the valves open, and is a jerky and bouncy movement. So this is the non-collapsible IVC and hepatic vein. This is a transthoracic image of IVC. Again, it's non-collapsible. So here we can identify the IVC in M mode. Due to respiratory excursions, sometimes the image vanished from the screen. But generally speaking, there is non-collapsible nature of the IVC as visible on the M mode. Here again, the findings are same. This is the inflow of the mitral inflow. Here we can appreciate, this is the mitral inflow velocity, the E by A waveform, the tallest wave of E velocity, that is early diastole inflow velocity, reaches around 140 centimeters per second, and the accompanying that, the late atrial contraction velocity reaches around 100 here roughly. So the ratio comes to about 1.55. The tricuspid inflow is showing respiratory variations here, as we can see, and with each respiration there is a increase and decrease in the inflow velocity across the tricuspid valve. This is also a sign suggestive of constrictive pericarditis. In tissue Doppler, we can see, as I mentioned earlier, the lateral annulus velocity was less than the medial. There is almost equalization of the waveforms. Pulmonary vein waveform, however, has not shown any much change in the structure. This is the hepatic venous waveform. The problem here was the M mode cursor couldn't be aligned with the longitudinal axis of the hepatic vein due to ascitic abdomen. Otherwise, somewhere we are seeing the flow reversals. So this is the MRI scan image of the patient showing septal bounce and jerky movement when the valves open and the ventricles fill. You can see it at this point. See, the septal bounced. So this is also the cross section where we can see the pericardial thickened layer. So the inability of the heart to accept adequate volume but preserved ejection is diastolic dysfunction. The filling of the heart has been hampered here. Then there were back pressure changes. It is evident that this is a case of diastolic dysfunction as a result of constrictive pericarditis based on the E by A value and the other values which I'll discuss later on. The determining the cause of pericarditis was a dilemma in this case based on clinical findings, as ascites, pleural effusion, and hydrocele may have multiple causes. Clinical examination rules out many other differential diagnoses. Doppler tissue imaging and mitral inflow Doppler confirmed the clinical suspicion and helped in excluding the other causes. Congestive gastropathy due to back pressure changes is the cause of hypoproteinemia. Inspiratory rise of E wave velocity of tricuspid valve was 33.3%. So this is a table that I have made. In our case, there is ventricular septal shift present. It has a specific sensitivity of 93%, specificity of 69. Change in mitral inflow E velocity, maximum by minimum, the ratio comes around 1.4 to 1.5. It falls in the pseudo-normalization range grade of diastolic dysfunction. There is the cutoff value of change in velocity is 14.6%, whereas in our patient it's 8.6%. So here again the sensitivity is 84%, specificity is 73. Medial A velocity is 11. Medial A velocity is 11. Yeah, right. So this is the finding which I said, that it is annulus reversus, where medial velocity in tissue Doppler imaging will increase as compared to the lateral. Cutoff value is more than 9 centimeter per second. Sensitivity is 83, specificity 81. And when we do the ratio of medial A prime by lateral E prime, they have, in our case, it is 1.25, whereas literature has suggested a cutoff of 0.91. Sensitivity is 75, specificity is 85. So this cutoff values have been taken from this study, which got published in Journal of American College of Cardiology. So according to this study, the ventricular septal shift and medial E prime velocity of more than 9 centimeter per second together account for sensitivity as mentioned here as well as in the table, 80, and specificity of 92%. E by E prime value of 15.55 was present in this patient. This is a sign of pulmonary capillary wedge pressure being more than 20 mm of Hg. This value has also been taken from the same study. So in this case, it was not possible to align the M mode along the hepatic vein, as I had discussed. That's why the flow reversal could not, that precluded the assessment of the flow reversal. And multiple procedures like pleural and ascitic tapping and future hydrocele repair surgery could be avoided once the constrictive pericarditis is managed for this patient. So thank you, everyone.
Thank you, Kedar, for that presentation about dilemma in diagnosis. May I request Dr. Mahala to take over and explain?
Thank you, sir.
Yes.
Yeah, thank you, Kedar, very much. Can you come
sir.
out of the screen?
Yes, sir.
Screen sharing.
Yes.
Yeah, one more point I wanted to highlight here is we have a patient who had a bypass surgery. That patient reported second time, pleural tapping was done, put an ICD, goes back home, comes back again, and this time he didn't represent to us. He went to the surgical site to have a hydrocele surgery. And the patient was referred to me for cardiological fitness for non-cardiac surgery. When I saw the patient and whatever the clinical picture was given, it was there, telltale. But the question was, the echo was absolutely fine. There is nothing suspicious. It is like an heart failure with a preserved ejection fraction. So the question was whether it is a restrictive cardiomyopathy, constrictive pericarditis, or as I said, or it was as reported in the investigation, there was a total serum protein was very low and albumin level was low. So is it generalized in anasarca? Or as there was a coarse echo structure or the liver ultrasound structure. So is it cirrhosis of liver with ascites and pedal edema? So the edge report was there previously after the surgery. The pericardium was thickened, but there was no clear-cut picture of constriction at that point of time. So now when we do the echo, this echo was done and reported as normal. When I reviewed the echo, so there are subtle signs of constriction which all of us miss. So is it very specific of constriction? We see the septal bounce, we see the filling pressures are elevated, we see the exaggerated filling on the right side and a reduced filling or output in the left side. So what are gold standard for diagnosis of constriction as in this case? As the patient has already gone a pleural tapping and he has gone and seen a surgeon for hydrocele surgery, are we on the right track? What if I would have given the fitness, looking at the echo, saying that ejection fraction is normal, and the patient can go for happy well post bypass surgery, can go for a non-cardiac surgery with low risk. So this was the question overall. So what are the parameters at this point of time? As Kedar pointed out, is the parameter sine qua non, or is it a patient of COPD carpopulmonale per se? We can get everything in COPD carpopulmonale also. So I can say it is COPD carpopulmonale. So that is also possible. So what we are dealing with, and how should we differentiate these causes? Restrictive cardiomyopathy, constrictive pericarditis, pericardial tamponade, effusive constrictive pericarditis, or COPD carpopulmonale. So we called clinically as restrictive constrictive physiology. It is not that easy clinically to differentiate whether there is a patient is having restrictive cardiomyopathy or constrictive pericarditis. So we use a general term, constrictive restrictive physiology. They will present clinically or the complaint-wise similar findings. So the echo-wise, what are the step 1 or step 2 point out in favor of constriction, not in favor of restriction? So this I wanted to highlight, as all of us can see that the Mayo Clinic data, they try to study the echo findings, saying that what are the real parameters we can favor constriction. So it is called exaggerated respiratory influence on heart feeling. Normally there is influence, but it is exaggerated. 2, the septal movement is changing, which changes normally, but not that much, which is seen here. 3rd is called augmented longitudinal contraction with the restriction of lateral contraction. So these are the 3 points happening that changes our echo findings. So let us examine one by one. Feeling pressures are high. So we know JVP is high, but mind reads something called Kushmal sign. In constriction, the patient takes a deep breath. Instead of JVP dropping down, it will go up. So that is called Kushmal sign. So that has influence in the Doppler. Second point is the feeling pressures. We have to check E by A, what is. It will show definitely a restrictive pattern. That is 2. Then septal shift, the septum moves. That is exaggerated or called septal bounce. Then, as I said, other side of the story is the longitudinal augmentation of the contraction. So that will be reflected in septal E prime. So these points were taken in the echo. So it was found out, if you look at the parameters, the septal bounce and plus one of the, like septal E prime or expiratory diastolic reversal in the hepatic veins. 3 points were concluded in the study. So if the 3 points are there, they are most suggestive or favorable with the sensitivity of 97%. If out of the 3, 2 are present, like septal bounce plus septal E prime or flow reversal in expression in the hepatic veins, one of them, then it is falls to sensitivity specific to 90%. If all the 3 signs are present, it is almost 97%. So the interesting part of this study, this patient was, IVC was dilated, non-collapsing. So the central venous pressure was elevated. E by EA flow pattern across the tricuspid was more than 1.5, which is the cutoff is 1.6 or 1.5. Then something called annulus reversus. Normally, the lateral annulus moves more than the medial annulus. They will be like this. But here, opposite, because of the augmentation of the contraction in the long axis, then the lateral wall or in the central part. So this E prime cutoff is 8. Anything above 8 of septal E prime is suggestive of constriction, not restrictive cardiomyopathy. But still, it is like who is the first? Hen is the first or the egg is the first? So confusion persists. So we depend on the gold standard investigation, CT or MRI. Is CT or MRI to tell directly, yes, it is constriction or restriction? The answer is they can detect the thickened pericardium or restrictive cardiomyopathy. They cannot say this is constrictive pericarditis. So we have to take the clinical pictures and echo findings into consideration. CT only says, or MRI says, pericardium is thickened more than 4 or 5 millimeter is suggestive of constriction, not the constriction. So we have to have clinical parameters to say there is a constriction. In the clinical parameters, again, there is confusion between so many factors. So we have to take the echo into picture. So echo definitely plays a crucial role, which we underestimate or we do not give importance to it. That is one point. So anything, Muralidhar, you wanted to highlight or wanted to?
No, absolutely interesting case. Just imagine if the patient had undergone surgery for hydrocelectomy.
Yes.
Based on the LVEF 50%, he might have had landed himself into problems. So we would not know how he would have behaved when this finding was based on LVEF. We have subjected the patient to surgery. So we have to take the whole picture into consideration when we think of doing non-cardiac surgery in a cardiac patient. And this is very unusual and very nicely presented. Thank you so much. What I would like to ask you is, what is the incidence of constrictive pericarditis after CABG?
Yeah,
do
the statistics,
patients, yeah.
Yes, statistics, I'll not tell you the exact percentage of post-surgery constrictive pericarditis, but this is the commonest finding current world. Earlier it was tuberculosis or the infection, but if you take the current constrictive pericarditis is a post-op.
Oh,
the commonest. The second comes the malignancy.
Okay.
The malignancy of the radiation or chemo or malignancy per se. The first commonest cause of constrictive pericarditis is surgical.
Right, right. The other question I would like to ask you is, when you found the mitral inflow velocity pseudo-normal,
yes,
somebody else would have thought that it is normal because the E is bigger than A.
Yeah.
So how did you think that it is pseudo-normal and not exactly normal?
Yeah. So these are a couple of points here. First, the patient is a post-CABG with a thickened pericardium. It cannot be normal. That is the common clinical background. Right. If it looks like E more than A and it is more than 1 or more than 0.8, one has to use the tissue Doppler.
Yes.
If the tissue Doppler will give you immediately A more than E or E more than A. So that is certainly one point. Here actually, the interesting part, we are not going to study the diastolic dysfunction in constriction. Because here you have to find out the criteria or the criterion which will suggest constriction. If E is more than A, it is a restrictive physiology. It cannot be A more than E, not relaxation failure. Right. So we'll be getting E more than A. So E by A ratio more than 1. But what is taken in constriction versus restrictive cardiomyopathy is more than 1.6.
Oh.
If E by A more than 1.6, it is in favor of constriction, then restriction. Restriction will have a E by A more than 1, but the velocity is lower. That is one point. Another interesting finding I wanted to share here is the COPD carpulmonum. You will get all what we have shown in this case. You will get septal bounce, IVC dilated plethoric, and you will get the dilated RA-RV, and you may get whatever everything described, exaggerated feeling across the tricuspid valve in inspiration, reduced feeling across the mitral valve in inspiration, everything, ditto. And second, here is very interesting part is E by A. E by A is more than 1.5 or 1.6 in constriction. It will be lesser than that figure in COPD carpulmonale. That's one point. Second point is we called, as I have said, Kussmaul sign in the superior vena cava. So, another interesting Doppler we don't do is the SVC flow. SVC flow, if you put a Doppler, something called a flat Doppler. So all of us should remember this word called a flat Doppler. What is flat Doppler? In the systole, the blood should return to the right atrium. So during systole, there will be a flat or attenuated or reduced return. You don't get a Doppler signal like this. So that's called a flat Doppler, which is found in constrictive pericarditis. In COPD, there will be a systolic flow which is returning to the heart. This is a very, very crucial and very important point. Then EYA, as I said. Otherwise, it will be telltale of COPD, carpal CCP to differentiate in echo. So I think all of us should utilize the SBC flow in constriction to get a flat Doppler during systole. In inspiration. In inspiration, categorically the blood column will go up, what is called Kushmal sign. It will not return towards the heart. So that is peculiarity. And the second point is, can we pick up the pericardial thickness in echo? That's another point. It is like, you diagnose constrictive pericarditis just looking at the thickness, what we do in the CT or MRI.
Yeah.
So it is difficult. I have 2 tips here to share. How do we examine or study the thickness of the pericardium? What we do is get an image, proper image, try to reduce the gain. Slowly go on reducing the gain till the endocardium, myocardium disappears from the screen. What it remains the pericardium. So you measure that. If the thickness is more, at least more than 4 millimeter, it is thickened. That is one tip. Second tip is, many patients of constriction, they'll have pleural effusion, like this patient.
Right.
So you have a pleural effusion and pericardial effusion, it becomes easier. They'll be separated, pleural effusion by pericardial effusion by the pericardium alone.
Yeah.
So if you have a clear-cut pleural effusion and pericardial effusion, you can jolly well measure the thickness of the pericardium. So these are the 2 points to be practiced while measuring the thickness of the pericardium. That will also give a clue. And sometimes you get the effusion or what is called effusive constrictive pericarditis.
Yes.
The effusion will be very minimal, not like a tamponade, but the patient behavior will be like a tamponade. So we call effusive constrictive pericarditis. That many times if people get 3 millimeter, 5 millimeter pericarditis, oh, it's a mild effusion, but not in the phase of constriction. Along with the constriction, even mild effusion, they will behave clinically like tamponade. So we call effusive constrictive pericarditis. The behavior will be tamponade. They can have raised venous pressure, hypotension, muffled sounds are called distant heart sounds clinically. So these are my viewpoints on this case. And by just giving or getting a suspicion in the echo, evaluating in the right direction, we saved this patient unnecessarily going for a hydrocele surgery or what has been the tapping. Again, there is pleural effusion. Somebody can put a needle and tap. And mind it, this is a curable disease.
Yes, yes. Thank you, Mahala, for highlighting the special points about diagnosis of constrictive pericarditis vis-a-vis restrictive physiology. Any questions or comments from the audience? Anybody wants to ask anything? Dr. Mahala is the expert echocardiographer, so if you have any questions, feel free to ask him.
I don't think you have explained everything.
It's an interesting topic, very interesting topic, very nicely presented. And I'm very happy that you could pinpoint the diagnosis before the patient was put to surgery.
Yes.
Very important.
Yes.
Anup, you have any questions for him?
No, sir. Dr. Mahala has very beautifully explained. It's a very complex pathology. So until we have an acute observation of the findings, we can miss many things, not just in echo, even in hemodynamic monitoring. So as Dr. Mahala said, the acute observation of even minor things can lead us to more sinister things that might be hiding in the background.
Yeah, that is true. The tendency is to just look at the EF.
Yes.
And if LVEF is good, you just go with surgery.
Correct.
And that is the general tendency. If we do that, we may actually miss out some important aspects of cardiac pathophysiology, which is highlighted in this case.
Yeah.
Anybody else wants to ask any question? If there are no questions, we will be winding this session. Any questions?
Any chat box questions? Something in the chat box? Are there any questions in the chat box? No.
No, sir, there is no question. If any question directly came to you, can have a look, sir. Because sometimes they will send direct questions.
I don't think I have any chat box questions here. No. On my screen, it is not there.
This case is a lesson for general anesthesiologists as well, because if you just go by LVEF, you might miss out some important finding which may be really crucial other than the EF.
Yeah.
So it's very, very, you have to go through the report diligently.
And honestly speaking, when people look at this echo of this patient in a gross, like a naked eye examination, it looks absolutely normal.
Yes.
So just look at the septum only, it is just little bouncing. The rest of the echo looks absolutely fine. EF is fine, not much of chamber dilatation in echo. Then when I went subcostally, even in spite of a big tummy, ascites, and all that, just to look at the subcostally, then you find the IVC is plethoric. And that clinches the diagnosis.
Sure.
Why IVC is plethoric? It was in my mind, so much of hyperproteinemia, albuminemia. Is it that the cause of swelling? Or is it COPD, carpal or is it coarse liver in the ultrasound?
Yes.
So cirrhosis of liver. Just looking at the IVC, dilated and non-collapsing. Then I started searching, looking at all the parameters like Doppler indices, even including the hepatic vein flow, all that what we got.
Yes. Thank you, Mahala. Thank you for
Thank you very much. Thank you.
Point. I think because there are no more questions, we can close the session. I would like to thank all the participants.
Thank you, sir.
And the faculty members, Dr. Mahala, Dr. Varun Shetty, Dr. Anup, Shraddha, Srinivas, and others who are present here, Dr. Jagadish, for participation. And please join us back tomorrow at 6:45 for another session of 2 cases and 1 short lecture. Different cases will be discussed tomorrow. Please join us. Thank you. Now I hand over this podium to Mr. Gunjan. Gunjan, please.
Thank you. Thank you very much, sir. That was really nice case discussions. I would like to thank all the faculty who presented today for the discussion that happened. So as Dr. Kanchi mentioned, please do join us tomorrow at the same time. We will begin at 7 p.m. sharp tomorrow as well for 2 more interesting cases with a lecture, beginning with a lecture. So please do join us tomorrow. Thank you very much. We can close the session.
Yeah, thank you.
Good night. Good night.
Everyone.
Thank
Good
you.
night. Good night.
Thank you, sir.
Good night. Thank you.
Good night, sir.